Question 1. A 65-year-old man has sudden blurred vision in his left eye, accompanied by dark streaks. He has hypertension and type 2 diabetes mellitus, managed with losartan, metformin and sitagliptin. Visual acuity is 6 and 24 in his left eye and 6 and 12 in the right. A fundoscopy shown on the right-hand side is shown below. Which is the most likely diagnosis? A. Age-related macular degeneration. B. Central retinal vein occlusion. C. Retinal detachment. D. Retinitis pigmentosa. Or E. Vitreous hemorrhage. The correct answer for question 1 is E. Vitreous hemorrhage, and we'll be going over the explanations in the following slides. A vitreous hemorrhage is a relatively common condition with a number of causes. It is characterized by the presence of blood within the vitreous cavity, resulting from a rupture of retinal or choroidal vasculature. The most common risk factor for vitreous hemorrhage is proliferative diabetic retinopathy. Other risk factors include retinal detachment, anticoagulant therapy, ocular or periocular trauma, sickle cell disease, vasculitis, bleeding disorders, and Terson's syndrome. Terson's syndrome is characterized by a combination of intraocular and subarachnoid hemorrhage, secondary to a berry aneurysm. Symptoms include an acute painless vision loss, visual haze, a reddish hue to vision, floaters, shadows or dark spots, and a reduced visual acuity. Regarding the management or diagnosis of a suspected vitreous hemorrhage, an urgent ophthalmology referral within 48 hours is required to exclude retinal detachment. Fundoscopic examination typically reveals a hemorrhage within the vitreous gel. Other supporting investigations include a slit lamp examination detecting the presence of red blood cells in the anterior vitreous, a fluorescent angiography, useful for identifying neovascularization. A B-scan ultrasonography is indicated when the posterior segment is obscured due to the dense vitreous hemorrhage. A brightness scan combined with an amplitude scan is utilized to determine the underlying etiology and hemorrhage characteristics. We can see in Figure 2 a characteristic depiction of a vitreous hemorrhage as shown on fundoscopy. On to the management. In cases where the causes of vitreous hemorrhage is unknown and the retina remains attached, initial management involves observation. Patients are advised to maintain a head-end elevated position to allow the blood to settle inferiorly, improving visualization. A follow-up evaluation is recommended after 3 to 7 days to reassess the underlying cause with clearer media. If an etiology is known, for example, such as post-laser hemorrhage or recurrent vitreous hemorrhage post-vitrectomy or Terson syndrome, observation for 2 to 4 weeks is considered, whilst also monitoring for potential retinal detachment. Additionally, in patients with active neovascularization, they should be advised to avoid strenuous activities or heavy lifting. If visualization of the posterior segment is obstructed, as discussed on the previous slide, an ultrasonography may be used to assess for retinal detachment. When a retinal break or detachment is identified, an urgent pars-planar vitrectomy is required, as shown in Figure 3. However, if the retina remains attached, outpatient observation is appropriate. If a break is found, it can be treated using cryotherapy or laser photocoagulation. Patients without retinal detachment may gradually return to normal activities. Once the retina is visible, patient management should focus on addressing the underlying cause. In the context of proliferative retinopathy-induced neovascularization, pan-retinal photocoagulation is the preferred treatment. A vitrectomy is indicated for persistent non-clearing vitreous hemorrhage or neovascularization of the iris or ghost cell glaucoma. Vitreous hemorrhage can lead to several complications, including hemosiderous bulbi, ghost cell glaucoma, as depicted in Figure 4, hemolytic glaucoma, amblyopia, and myopic shifts. In hemosiderous bulbi, a rare complication is caused by a release of iron from hemoglobin breakdown. Iron is initially stored in macrophages as ferritin hemosiderin, but can later be released into the vitreous, resulting in deposition within the ocular structures. Ghost cell glaucoma occurs weeks after vitreous hemorrhage, as red blood cells undergo degeneration. Over 1 to 3 weeks, Red blood cells lose their normal shape, becoming rigid, khaki-coloured ghost cells containing denatured hemoglobin, known as Heinz bodies. Now, D cells migrate to the anterior chamber when the anterior hyaloid face is disrupted, commonly after trauma, vitrectomy, or cataract surgery. In the anterior chamber, ghost cells obstruct the trabecular meshwork, leading to secondary open angular glaucoma.